In Chapter 11, we will be covering the basics of injury rehabilitation. Some of the information we go over in this chapter will seem similar to the information that we covered in the fitness chapter. However, there are differences between rehab and strength training. So as far as therapeutic exercise or rehabilitation, we use exercise only as a part of a rehab program. This is for athletic trainers and physical therapists only. As far as conditioning exercises or strength training, conditioning has a completely different goal. So those are activities that are used to minimize injuries and maximize performance. So even if we use a similar type of exercise or even the exact same exercise in rehab versus strength training, the goal is different. So that's what makes the two areas so different. The nice thing is that most injuries do not involve long-term rehabilitation programs, but those that do require supervision of a highly trained professional. An athletic trainer or a physical therapist can design, implement, and supervise a rehabilitation. A certified strength and conditioning specialist or a personal trainer is not technically qualified to do those things. So after an injury, swelling and pain control should be provided immediately. This is the beginning of the rehab process. So when we see an athlete who's been injured or a client who's been injured, we put ice on them right away. That's actually the beginning of the rehab process. Maybe we'll give them some easy exercises to do on the field when they're injured, splinting them appropriately. All of those things would be the start of the rehab process. We have to be prudent in decisions regarding aggressiveness of treatment and rehab or return to play. A mistaken judgment by the individual in charge of the rehabilitation could hinder the athlete's return. This particular picture is actually somewhat gruesome. My head athletic trainer in college actually knew this individual. He was a triple jumper who was jumping in the Olympic trials, trying to qualify for the Olympics. And he knew he had a stress fracture in his tibia, but because he knew he wanted to qualify for trials, he chose to compete anyways. And as you can see there, he caused a complete fracture in his tibia. So the individuals in charge at that time should have withheld him from competition at that time. Athletic training and sports medicine were a little bit different in this time period. I think this was sometime in the 80s. So our field was still growing, and doctors still had different amounts of say in people competing at an Olympic level, especially. There are some basic components and goals that need to be considered in a rehab program. We have long-term goals and short-term goals. So these are examples of what we could be using as a long-term goal or a short-term goal. These are not the only goals that people will have. One long-term goal would be to return to activity as quickly and safely as possible. That's a pretty general long-term goal. It would be better for somebody to have a specific long-term goal, like I would like to be able to play 18 holes of golf without pain, or I would like to run a mile with 2 out of 10 pain. Something a little bit more specific would be better. But for most rehab programs, returning to activity as quickly and safely as possible is a very good general long-term goal. Short-term goals could be things like we're going to control swelling, we're going to control pain. Maybe more specific would be we would like the patient to have 2 out of 10 pain by their 3rd week of rehab or something to that effect. We want to restore full range of motion. So in a post-operative plan, we might say that we would like to restore range of motion of the knee to 90 degrees by the end of week 2, say for instance. So more specific is better. Restoring core stability, we want to, which is very important. We want to restore and increase strength, endurance, and power. We also want to reestablish neuromuscular control and balance, and very important but often overlooked, We want to try to maintain levels of cardiorespiratory fitness. We will go over each of these short-term goals to try to explain how we're going to achieve them as we go through the chapter. So our first goal is to control swelling. If we don't control somebody's swelling, then they will have less function and they may not heal as well, as we've already discussed in a previous lecture. So our initial first aid is critical for swelling control. So the price, the protection, rest, ice, compression, and elevation. Each factor is critical in limiting swelling. Again, our compression and elevation are more important probably than the others, but we definitely don't want to be continuing to irritate injured body part because that can contribute to swelling. Swelling can shut down the muscles in the surrounding area and make rehab harder or not as effective. So remember, when we elevate, we want to elevate above the heart and use an ACE wrap or a compression wrap. For this particular individual, you can see she has swelling all the way down into her foot, all the way here back around her ankle, and even up into her leg. So this whole area is swollen, and that's probably all from an ankle injury right in that general area. So she got very swollen. Controlling pain is also very important. With most injuries, some degree of pain will be experienced. If somebody has an injury and pain is not experienced and it's a severe injury, that actually scares me a little more because that's telling me they may have some nerve damage. But generally speaking, people have some degree of pain. Pain and what the amount of pain that somebody is reporting to you can be affected by a lot of different things. So pain depends on the severity of the injury partially on the athlete's response to pain, and their perception of pain and the circumstances surrounding the injury. So some good examples of those things would be some people have a very high pain tolerance. So they get hurt, they feel the pain, but they kind of just figure that they'll live through it. It'll be okay. Some people have a very low pain tolerance. They stub their toe and they're crying for a week. So everybody's a little different with their pain tolerance. But on the other side of that too, individuals have different perceptions of the amount of pain that they have as well. So, so somebody could get the exact same injury to the exact same body part, and their pain could be a 2 out of 10, which is pretty mild, and then another person could get the exact same injury, and their pain could be a 7 out of 10. So one time I saw a little 12-year-old girls lacrosse player on the field, and she had like a mild to moderate ankle sprain. It wasn't that bad. And she was just sobbing, and it was 10 out of 10 pain. It was the worst pain she's ever imagined. And when I told her, 10 out of 10 pain means you want to die to stop it. And she's like, I want to die to stop it. So, but most people with a moderate ankle sprain would tell you it was a moderate amount of pain. So it'd be more like a 5 out of 10 pain. So it depends on the person's perception, what their previous experiences have been with injuries, but then also what are the circumstances. If it's a senior football player's final game and they sprain their ankle, they're going to tell you it feels great. They're going to tell you they don't care if it hurts. Their pain rating is probably going to be very low. They may not even feel it that much until the next day because their endorphins are so high. Or if somebody's making a big deal about it, somebody might rate their pain as being higher. So with little kids, if they fall down and you make a big deal about it, they're going to cry. But if you don't make a big deal about it, most of the time they're a lot calmer. So there's lots of different things that go into the amount of pain somebody feels with an injury. We can use price and other modalities like electrical stimulation and heat to help modulate pain depending on how far from the injury they are, how long. Pain can interfere with rehab, and we do need to address that. So we don't want to ignore the fact that somebody's in pain. We may still ask people to try to do exercises gently, even if they are having even 10 out of 10 pain possibly. But the problem is that pain messages can shut down the muscles in the injured area, just like swelling can. So we want to try to do our best to modulate an individual's pain when they're trying to perform rehab exercises. As we were discussing on the previous slide, there are some different ways to describe pain. So most often we use a scale of 1 to 10. So usually I tell a patient or an athlete, on a scale of 1 to 10, how bad does it hurt? 1 means you can barely feel it. The pain is more annoying than anything. 10 is the worst pain you can imagine, and it hurts so bad you want to pass out or die to stop it. Sometimes in the physical therapy clinic, I'll say 10 out of 10 pain means that you need to go to the emergency room to get medication to stop the pain. Sometimes for children or people who have disabilities, or for people maybe who don't speak English, we may use a FACES pain scale. So the FACES pain scale is down here. So what we're looking at here is 0 would be no hurt. So smiley face, I'm very happy, no hurt. 2 hurts a little bit, but I can still stand it. 4 hurts a little more. 6 hurts even more. 8 hurts a lot. 10 hurts the worst. I'm crying because it hurts so bad. And that's another option if somebody is not understanding our 1 to 10 scale. There are also different types of pain. So pain can be sharp, stabbing, throbbing, dull, achy, and burning. There could be other ways people might describe their pain as well, but some examples of injuries that could go along with these kinds of descriptions would be like an ankle sprain or a muscle strain would usually be sharp at first. Stabbing pain could be a way that somebody would describe a strain or a sprain. People also often feel throbbing with a contusion or swelling. Dull pain can indicate general muscle tightness. Aching pain can be general muscle tightness or possibly a bone injury or sometimes arthritis. Burning pain would be a way that somebody might describe a skin injury and or a nerve injury. We talked about range of motion a bit during the fitness lecture, but restoring range of motion is very important during rehab if the range of motion is limited. Oftentimes, injury to a joint is associated with some loss of motion, and this happens because of what we call a contracture of the connective tissue. So that means that the joint capsule or the ligaments surrounding the joint tighten down. Or there could be a resistance to stretch because of the musculotendinous unit. So the muscle and tendon get tight with that joint because we're getting some muscle spasm when the body is trying to protect the injured joint. So the athlete will need to engage in some kind of range of motion exercises. So either dynamic, static, or PNF stretching activities to improve flexibility. If somebody has a newer joint injury, we're absolutely not going to have them do dynamic or PNF stretching, most likely. They would probably do more static stretching. We want to be very gentle when somebody has a newer or acute injury, and then as the injury becomes what we call subacute, or a little bit later on, we can start to add in some more gentle activities like PNF stretching, gentle PNF stretching, and then as the injury enters more of a chronic or maturation remodeling phase, we can start to introduce more dynamic stretching, generally speaking. And again, on the bottom of this slide, we are going to use that good old goniometer to measure joint range of motion. Restoring core stability is very important. However, it is sometimes overlooked with extremity rehab. We try to restore core stability when somebody's been injured because we can use it to prevent and treat further injuries, specifically to the spine and lower extremity. But if we have good core stability to start with, we actually do prevent injuries better. Having good core stability improves efficiency of movement, particularly with the spine and pelvis, but possibly with the hips as well. And this can improve function following an injury. So this is helpful with going up and down stairs, getting in and out of a car, changing direction while running, things like that. There are 39 muscles in the core, but we're only going to talk about 2 on this slide. We have the transverse abdominis, which is the deepest abdominal muscle. So your superficial abdominal muscle, most superficial abdominal muscle is your rectus abdominis, your six-pack muscle. That's a primary mover. So are your oblique muscles, they're primary movers. Your transverse abdominis is not really a primary mover of the torso. Its main job is to hold your guts in, actually. So if we wanted to contract the transverse abdominis, we actually draw the navel in towards the spine because that holds our guts in more. The other interesting thing about the transverse abdominis is that it's the only abdominal muscle that attaches to the spine. So if we are doing a good job of using this muscle more often and this muscle is strong, it will support our back. That's one of the reasons why we use it often in back rehab. With transverse abdominis activation, we're looking for flat abs, not a six-pack. So we don't want any crunching with this particular activity. But if you look to the right of the right-hand slide on the top, you'll see an individual laying on their back, laying supine, and they're going to draw their belly button in, and that drawing in will slightly flatten the back. We don't want people to purposefully flatten their back as the primary movement of this exercise, because if they do that, oftentimes it will recruit other muscles like the gluteus muscles to help with that. The main motion here is just drawing the belly button in, and the back will incidentally become flatter. This exercise is very important when we're starting somebody with back rehab. Another muscle that's very important to get stronger with for the core is the gluteus medius. This is important for back injuries. This is important for knee injuries and hip injuries. The gluteus medius is on the posterior side of the pelvis, attaching into the hip, and its main job is, well, hip abduction, but as a stabilizer, its job is to keep the knee pointing straight. So it's going to avoid letting the hip go into adduction. So it's going to stabilize the knee in a more neutral position. So ideally here, what we'll do is if we're contracting the gluteus medius properly, we'll have the ASIS, or the point on the front of the hip here, will end up in line with the middle of the knee here, and then that line will end by going through the second and third toes. So I call this is what I refer to as railroad tracks. So if an individual is really contracting that muscle, we'll have a pretty straight line, even in a squatted position, between those points. Now it's not always essential to keep railroad tracks. So when somebody is doing change of direction, they're not going to always keep their knees on railroad tracks. But if somebody's having knee pain or hip pain or back pain, we want to train this position to start before we have them starting to do different positions with their knee with change of direction. This is an exercise that I really like. It's called the organ shift drill. So basically, I don't know why it's called that in particular, but that is what it's called. Basically, the individual will sit down a little bit with their hips. So they'll be sitting into a nice squat here, and then they'll spread their arms open wide. And depending on how functional they are, it's going to depend on how deep they can squat. If it's an older person, I might put them in a doorway to make sure they don't fall over, because this can be somewhat challenging if you're doing it right. So we'll have them in a little bit of a squat, and then while keeping that nice straight line between all of those points, the ASIS, the knee, and the second and third toes, they're going to sit to one side with their hip. So this is a stabilizing activity. So it's a real small movement. They're going to sit to one side, and then they're going to come back. And then they're going to sit to the other side, and then they're going to come back. So real small motions here, just kind of trying to perturb or throw the person off balance just a little bit. So it's not super big movements. If you try this on your own, you'll see it's actually a bit more challenging than it appears at first. Occasionally people in class will say, oh, that's really easy. If you're doing it right, it shouldn't really be that easy. So that is strengthening the transverse abdominis and gluteus medius. Restoring muscular strength, endurance, and power are all very important when it comes to rehabilitating an injury. These are our most important factors when restoring function to pre-injury status, assuming that the person has relatively normal range of motion and core strength especially. So as we discussed in the fitness lecture, we have a couple of different techniques to do this. We can use isometrics, progressive resistance exercises, isokinetics, and possibly plyometrics. So again, for isometrics, we're going to hold one position, and we'll mostly use this in early rehab. Our progressive resistance exercises may also be known as isotonic exercises. These are our most often used. Isokinetics are not very often used, but that's going to be a constant resistance, and we'll use this. We'll do this with a special machine. And plyometrics would be like hopping and jumping. We're going to primarily use in later rehab, right before return to play. With all of our muscular endurance, strength, endurance, and power exercises, we want to emphasize a full, relatively pain-free range of motion. So if somebody can't do a full range of motion pain-free, we limit their motion until they get stronger and are in less pain, and then they can do more range of motion as they go. They will not always be in a limited range of motion, hopefully. So neuromuscular control is very important when somebody is rehabilitating from an injury. Our body loses some ability to communicate between the nerves and the muscles when there's an injury, because the chemicals that are brought to the area actually kind of confuse the nerves in terms of perfectly calling up the muscles to work properly in the area. So if I've sprained my ankle stabilizers purposely shut down so that I don't use my ankle. It's a anthropologic adaptation to making sure that I don't hurt myself worse. You know, back before we had splints and crutches and all those things, our bodies would swell and our muscles would stop working as well to try to keep us from being active. From a primitive standpoint, you know, if I sprain my ankle and then I'm trying to go out and hunt, I could easily get injured and die if I'm trying to hunt on a sprained ankle. Our bodies don't realize that that's not an issue so much anymore. But reteaching neuromuscular control is really important when somebody's returning from an injury, because the body has purposely shut that system down a bit. So we need to relearn that. So neuromuscular control is the brain's attempt to teach the body conscious control of a specific movement. The brain and spinal cord interpret and integrate sensory and movement information, and then they control the muscles to produce the movement. So that would be like if you're walking on uneven ground, your ankle mostly on its own can tell that things are uneven, and your brain doesn't have to think about it too much. But after an injury, you may need to think about how you're controlling your ankle a little bit. The reestablishing of neuromuscular control requires repetition of movement until it becomes automatic. So after an injury, you may be somewhat of a novice at controlling your neuromuscular control, at controlling the muscles in your ankle, say for instance. But as you repeat the motion, as you get more used to it, and as you've been doing it for a while, you'll become an expert again, and you won't have to think about it as much. We do this by progressing from simple to difficult tasks. So if somebody has sprained their ankle and we're trying to reestablish neuromuscular control, we may do that by asking the person to draw the ABCs with their toes, because that teaches them to consciously put their ankle in different positions. After that becomes easy, and if they can start to bear weight, we may ask them to do a double leg balance so that the injured ankle is protected, but it's starting to learn how to do balance again. Then we may progress to single leg balance, then single leg balance on an unstable surface, and then continue to progress that to a more unstable surface until we can go to hopping and jumping and things like that. It is very important to use functional exercises for reestablishing that control. So I'm not going to think that somebody's going to be able to return to running after only doing some TheraBand resistance exercises. They need, for an ankle sprain, the individual is going to need to do some kind of balance and possibly some landing strategies or hopping as well before they can return with full control. One important concept with neuromuscular control is called proprioception. That's our unconscious knowledge of where a body part is in space. So if you close your eyes and you reach back behind your head, you can have a pretty good idea of how far you are away from your head, right? So if you're going to try to reach and pat yourself on the back with your eyes closed, you can do that because you know where your body parts are in space. If you sit next to somebody and you close your eyes and you reach out and start to try to touch them, you have a pretty good idea of when you're about to touch them, right? So that's you have that unconscious knowledge of where your body part is because you have sensors in your joints that understand movement. And that's what we're trying to retrain with our neuromuscular control techniques. So along with that neuromuscular control, regaining balance is very important. Our ability to balance and maintain postural stability is essential to reacquiring athletic skills. If somebody can't maintain their balance, they're going to get injured again. Our primary mechanism for controlling balance is in the joints of the lower extremity, like the ankle, knees, and hips. But also our core can relate to that as well. If an athlete lacks balance or postural stability, they may lack proprioception and or muscular strength, and this can impair their response to being off balance, which will in turn make it more likely for them to be re-injured. So if somebody starts to become off balance, they're more likely to twist their knee in a bad way or fall over, which can make them get hurt worse. A rehab plan must incorporate functional activities like balance and proprioceptive training if it's going to be fully effective to return somebody to sport or high functioning daily activities. If we don't include that in rehab, it really increases the chance of re-injury, especially if it was a lower extremity injury. Maintaining cardio fitness is very important, and it is the most neglected component of rehabilitation. Part of that is because, especially in a physical therapy setting, you have maybe 30 minutes to an hour with somebody. And if this person has been an athlete, they're probably used to doing cardio for a lot longer than that. And also the main goal in physical therapy is to, regain strength and range of motion and balance. So the individual is going to be responsible for doing their cardio on their own. And a lot of people just really aren't that great at doing that when they don't have that structure of an athletic practice. So when an injury occurs, the athlete's going to miss training time, which then will decrease their cardiorespiratory endurance. So they're going to have to do extra training on their own. Oftentimes we'll have to have alternative activities for them as well. So if somebody has an ankle sprain, they're not going to be able to run on it. It may hurt them to bike or even swim, so they may have to do something like arm bike. If somebody has a shoulder injury, they may be able to do something like aqua jogging, but if they jogged, it would put too much stress on their shoulder and the bouncing would hurt them. But they might be able to bike, say for instance, even if they're still in a sling. So most of the time we can find something for somebody to do that's not going to aggravate their injury. We do want to try to add cardio as early as possible in a rehab program. So examples would be aqua jogging or arm bike for lower extremity injuries possibly. On this page, we're going to talk about functional progressions. So a functional progression means that we're going to start with a more simple exercise and we're going to progress it into being a more functional, possibly more challenging exercise, but hopefully more useful as far as sport or activity goes. So we're going to have a series of gradually progressive activities in preparation for a specific sport or activity. Basically, we try to take sport-specific skills and break them down into separate components, and then the athlete will work to reacquire those skills over time. One particular skill that's very applicable with most sports would be a squat or a lunge. So with the squat, we're going to start off with a double leg squat, maybe not even this deep. maybe the person would do a mini squat where they were just coming down just a little bit. If they can't do a mini squat, maybe they can just do the hip hinging portion of the squat without bending their legs if they have a knee injury, say for instance. But once somebody's getting good at a regular squat, so maybe, maybe 90 degrees, so he's a little far down into the squat, but if somebody's having, getting good at like a 90-degree squat and they're not having any knee pain, if it's a knee injury, then we might be able to move them into doing a lunge like this. Now, if the individual has a left knee injury, say or a left knee injury like this, or so this person has her left knee forward, having that left knee forward, if they have a left knee injury, is going to be a more comfortable lunging position than having the left knee back. Having the left knee back puts more stress on that knee. So this knee in the back has more stress on it than the knee in the front. So if we're talking about giving knee lunges as a rehab exercise, we really want to be cognizant of the fact that the person could have more pain with that knee back, but they might be just fine with that knee forward. Next, if lunges are fine, we can do a single leg squat, maybe a mini squat here with that knee. Just starting to slowly work our way up into having good balance and good control with that exercise. If they need to hold on to something for balance, that's just fine. But as they get better with that single leg squat, we could have them try to do some little mini hops. So usually I don't start with single leg hops, but this would usually be kind of what our ending exercise might be. We might do double leg and then maybe 2 legs off and then 1 leg landing and then to single leg. So there can be even a little bit more progression between these exercises as well. But this would be a very functional exercise for somebody returning to sport with a knee injury, say for instance. We should try to incorporate these functional progressions into treatment as early as tolerated. So usually if I was rehabbing an ACL reconstruction, an ACL surgery, I would start doing mini squats as soon as the doctor cleared them to do that or cleared them for weight bearing. So usually within my first 1 to 3 visits with them, so kind of 1 to 2 weeks, they would start that as long as they were cleared by the doctor. If pain and swelling doesn't arise, then the activity should be advanced, again assuming that the individual has good control with that activity. With the functional progressions, you'll gradually assist the injured athlete in achieving their normal pain-free range of motion, strength, and neuromuscular control. So we want a gradual progression, not a super quick progression, because we want to make sure the person's not going to re-injure themselves. Functional testing is a completely different idea. Functional testing uses functional drills to assess the athlete's ability to perform a specific activity. Functional testing is usually a single maximal effort to gauge how close the athlete is to full return. It's really, really, really nice when we have a preseason baseline test for comparison, but we don't always get that. Oftentimes, if you have a college athlete that works with strength conditioning, you will have some sort of baseline. If we don't have that, say for instance, if somebody just hasn't done any testing for these particular exercises and they've had an ACL reconstruction or an ACL surgery, then what we can do is we can compare their injured side to their well leg. So we might say injured leg versus well leg when we're doing the testing. And when I do functional testing for an ACL injury, usually I'll tell people, I don't expect you to pass the first time. I expect you to get used to the exercises. Nobody passes the first time. I've never had anybody pass the first time, because my criteria for passing a functional test is that the individual on average for all of their scores needs to be at least 100% of their strength of the well leg. So the uninjured side and the injured side need to be equal. That's my goal when having somebody do functional testing. I also don't do functional testing if I haven't been training those exercises. So we should have something that we've been going through their functional progression that's somewhat similar to their functional testing. You don't just randomly start functional testing somebody with vertical jumps when they've never even done a single leg squat. That doesn't make any sense. So some examples of tests would be a shuttle run. So that's like you run, change direction, run, change direction. Agility runs. So we might do like a T pattern where they run straight ahead, stop, shuffle, stop, side shuffle the other direction, stop, come halfway back with the side shuffle, stop, and then run backwards in the shape of a T. Another thing they could do is figure eights, getting progressively smaller to tighten the turns. So that's, with those guys, you're not going to be able to compare well leg to unwell leg very well, or to injured leg very well, because you're using both legs to run. But for the other testing, like vertical jumps and balance and hopping for distance, you can. So we could do a vertical jump as high as you can off of the well leg, and then compare that to a vertical jump as high as they can off of the injured side, if that's appropriate for their sport. We do single leg balance for time, usually just literally as long as they could do it on each leg. And then hopping for distance. So again, I wouldn't have somebody who's never hopped before in their rehab try hopping for distance. I usually would work them up to that. Hopping for distance is very helpful, and having that be a part of a rehab program is very helpful for reducing the risk of recurrent lower extremity injuries like knee and ankle injuries, as long as the individual isn't getting more pain from that. So switching gears a bit, we talked a lot about the rehab exercise side of rehabilitation. Another part of rehabilitation that can be helpful is using therapeutic modalities. Now, modalities are not, I'd say if I had a choice, I would definitely choose exercise over modalities. If I don't have time to do exercise, or if I don't have time to do exercise and modalities, I would choose exercise. Exercise is a lot more important for long-term results when it comes to the healing process. Having said that, modalities are nice, for pain control and things like decrease in swelling, and we can increase the healing rate a bit with these. But we're using these therapeutic modalities as an adjunct to exercise, so it's an additional thing that we can do to help. We do like to use cryotherapy or ice and thermotherapy or heat for pain control and things like that. That is usually our first line of defense. If we have this available, we can also use ultrasound, electrical stimulation, and or laser treatments. Other treatments that can be helpful are massage and traction. And traction is a special kind of stretching. So when we talk about electrical stimulation and ultrasound, we can have a unit like this. This is an eStim unit that has both of those settings involved there. This is the output of the machine, and then the electrical stimulation pads are right here. You plug the machine into those pads to then send a low voltage electrical current through the skin and into the tissues of the body. That can help modulate pain and possibly help promote healing. The other thing that this machine can control is ultrasound. So this is a picture of ultrasound. Ultrasound is thought to help increase the temperature of the injured tissues. So it's basically a form of deep heat. Some people think it can also help with the healing process, possibly. The research studies on ultrasound have been somewhat inconclusive. It's not the end all and be all. Some people are really in love with it. I haven't really noticed big enough differences in my 20 years of being in the industry to think that it's really that important. And in fact, I haven't even used it in years. I think laser can be a little bit more helpful. The other nice thing about laser versus ultrasound is that laser treatments are a lot quicker. But there's lots of different kinds of lasers and lots of different kinds of treatments you can do with lasers. So, every one of them could be different, and the research on each one might be a little different. Some people love massage. I think it's the best thing ever. I don't do very well with massage. I do better with acupuncture, actually. But a lot of people, love massage. Patients like to be touched. If you give somebody a massage, it's like petting them. It'll help calm them down. There's a lot of different nice things about massage. A lot of people really love it. All of these modalities require special instruction and clinical experience to use appropriately, so that's one thing to be aware of. And again, our goal is to decrease pain, decrease swelling, and or increase healing rate. So some specifics for ice. Again, ice is pretty much our first defense usually when it comes to injuries. We can use ice for analgesia or pain control and to minimize swelling. Oftentimes we'll use ice bags in an athletic training setting. So that will be in this particular picture, that's an ice bag. That's a common way to ice, or you can use frozen peas possibly. You can also use ice from ice cube trays if you don't have the really nice ice like in that picture. You can place ice directly on the skin if the person does not have a known skin sensitivity to cold, and the ice bag can be placed for 20 to 30 minutes. In younger patients, I kind of should asterisk that. In older patients, sometimes their skin is a lot more sensitive. So generally speaking, in the physical therapy clinic I work in, I just recommend that people put the skin over a thin cloth or over a t-shirt or something to that effect. We try to be really careful with using ice on the genitals or on the eyes. If we are going to use ice on body parts with very thin skin, we want to make sure that we have some good insulation between the ice and that thin skin so it doesn't cause frostbite. Nobody wants frostbite to their genitals. The other way we can ice is using a chemical cold pack. So you can use a store-bought chemical cold pack, or you can make your own at home by filling a 1-gallon Ziploc bag with water and adding a few capfuls of really any type of alcohol. So it could be rubbing alcohol, it could be vodka, whiskey, whatever. Depending on what kind of alcohol you're using, it will change how much you need to use to make the right consistency with that cold pack. It should turn somewhat slushy, and should not be solid or just straight water when you take it out of the freezer. If it's too watery, then you dump it out some of that water and you add more water. If it's too hard, then you would dump in a little bit more alcohol. But you want to freeze that gallon Ziploc for 24 to 48 hours and then check that consistency. With any type of chemical cold pack, so if there's anything added to water, we want to use a barrier because anything added to water can lower the freezing point of that water and make the ice too cold to put on your skin. So we always want to use a barrier with chemical cold packs, and we want to make sure we're not icing for longer than 20 minutes to avoid frostbite. Another way we can ice is by using ice massage. So basically, in this picture, it's showing us somebody had frozen water in a Dixie cup, and then when the Dixie cup was frozen, they peeled off the top of the Dixie cup, left the bottom as a handle, and then rubbed the ice cube on their injured body part. The nice thing about ice massage is that you don't have to do it for as long. So you only do it for about 7 to 10 minutes, and that's pretty effective. You just do it until the area turns bright pink. The not so nice thing about ice massage is that it can make kind of a mess because the ice is going to melt all over the place. But it's pretty nice for certain body parts. So heat or hot packs are going to be kind of our secondary line of defense. So usually we'll use ice first, and then we can use heat later on after that first 72 hours. So we're going to use heat post-acutely, so after the swelling has stopped. Heat is nice because it can increase blood flow and facilitate reabsorption of injury byproducts. It's also really nice as an analgesic or pain reliever and for relaxation, just general relaxation, but also the muscle relaxation. We do want to be careful not to use it too soon in the healing process because we don't want to aggravate any acute inflammation that's there. So we're only going to use that cold for the first 72 hours post-injury. The way that we usually use hot packs in a physical therapy setting or an athletic training setting is to use moist heat packs, like a hydroculator pack. I know that's not spelled like it sounds. It's spelled hydrocollator, but that's not how you say it. It's hydroculator. So we're going to use those hydroculator packs, which is a cotton pad that has silicate gel in it, and it gets really hot. So we're going to maintain that in a very hot water. It's about 160 degrees Fahrenheit. So a hot tub is usually about 100 to 110 degrees Fahrenheit. So that hydroculator water is really darn hot. If that water has been hot and the pack's been in there for a little bit, that pack will retain heat for at least 20 to 30 minutes, sometimes longer. It can be really easy to burn a patient with a hydroculator pack, and so either the patient should not lie on top of the pack, or you need to place a lot of layers of towels in between the pack and the patient's skin. You can make your own hot pack using dry rice in a sock or a pillowcase and microwaving it until it's warm. Just be careful because you don't want to make it too hot. There's also plug-in hot packs that you can get as well, but those are known as dry heat packs normally, so they're not quite as effective. The moist heat will go deeper into the skin. So massage. Most people love massages. If you say you're going to give somebody a massage, they usually think, oh, that sounds nice, right? So massage in and of itself is just known as a manipulation of soft tissues, so skin, fat, muscle of the body. We can do massage with our hands or with different tools. So we can actually teach somebody to massage themselves using their hands or tools as well. But generally speaking, if we're going to be doing massage with our hands, it's going to involve a gliding, compression, stretching, percussion, and or vibrating. So gliding is when you think about just kind of sliding your hand up and down the person's back. Compression would be like the kneading that sometimes people do to another person's shoulders to help relax their shoulders. Stretching is where you can use both hands to kind of stretch the tissue apart. Percussion is when you pound on the back, and vibrating is when you take your hand and kind of just jiggle the tissue side to side. Massage causes mechanical, physiological, and psychological responses. So again, there's a reason why people will pay a lot of money to get a massage. There's a lot of different benefits with massage. We can use massage for a lot of different things. We can use it to encourage our lymphatic drainage, which can decrease swelling. We can use it to stretch superficial scar tissue. It's not as good with stretching burn scar tissue, but it's good with other kinds specifically. We can use it to stretch connective tissue, like the connective tissue of the muscles or tendons. We can use it to increase circulation, and it will also increase the metabolism in that area, so that can help to heal a bit as well. And it's also very good for relaxation. And if somebody doesn't have access to another individual who can massage them, we can also do massage with foam rollers or massage roller sticks or tennis balls or lacrosse balls or any number of different objects as well. Our last thing to consider when it comes to a rehabilitation process is what is our criteria for a full return to activity. So before even the rehab starts, we need to have our rehab plan determining what is meant by complete recovery. So for complete recovery, the athlete should be fully reconditioned, have a full range of motion, full strength, neuromuscular control, normal cardiovascular fitness for the sport, and sport-specific functional skills. So their functional testing should be good. Not only that, but the athlete also has to be mentally prepared and confident that they will not get re-injured. And that's not always the case with long-term injuries. Sometimes that part takes longer than the actual physical recovery. But that's part of why I like to use the functional testing and making sure that the person can see on a piece of paper that their injured body part is 100% of the strength of the other side, because that actually helps to feed into helping them feel more mentally prepared and confident as well. The decision to return to play should be a group decision as far as the sports medicine team, but ultimately the team physician is responsible for clearing that person to return to play or not. The athletic trainer cannot override the team physician when it comes to clearing somebody to return to play if the team physician has been responsible in that individual's care. Now, if I have an athlete who has an extremely conservative surgeon that was not our team physician that did their surgery, and that extremely conservative surgeon says that somebody with an ACL reconstruction can't return to play sooner than a year post-injury, then what I would probably do in that case is ask the individual, the athlete, to see the team physician and see if the team physician agreed or if the team physician thought that the individual should be cleared sooner. If the team physician thinks that athlete can be cleared sooner than the athlete's surgeon and the team physician is willing to take that responsibility, then that individual can play more quickly. And that is the end of our rehabilitation lecture.